Everyone, good morning, and thank you so much for joining us for our last session of the day, our interprofessional panel. We have some very distinguished guests lined up for you all, and so I'm just going to step back and let them introduce themselves. And I am Rachel. I'll be the moderator for this session. So throughout this session, you can ask any questions you might have in the chat, and we'll add them to the Q&A as we have time for. Okay, so I'll turn it over to our panelists to get started. Why don't we start with Brian?
Hi, everyone. My name is Brian Thomas. I'm a graduate originally of Rutgers University. I went to pharmacy school there, and I started my career off as a intraspinal infusion therapy pharmacist, focusing on pain management and cerebral palsy and multiple sclerosis patients. But then I continued on to residency with the Commission Corps of the United States Public Health Service, the both illustrious and infamous at times, and there's a history that I'm sure many people know about the PHS. I did my residency and worked out at Lakota Nation at Suisan Indian Hospital in South Dakota. And then I transferred to the Food and Drug Administration, where I worked in tobacco regulation for sales to underage youth in our country. And now I am currently a medical student, second year at Rowan School of Osteopathic Medicine. So it's a little bit about me.
Thank you, Brian. Let's have Ms. Vanessa Atkins go next.
Good morning, everyone, and thank you so much for having me as a part of this session. I am excited to be a part of today's panel to talk about interprofessional learning because I have really been very passionate about it throughout my career. I'm an educator by trade, though I do have a degree in biochemistry, so I feel the pain of those who are feeling a little overwhelmed by some of the intense science coursework that you're taking, especially those who are undergrads. But all of the work that I've done throughout my career has been focused on helping students who are underserved, who are disadvantaged in some way, gain access to higher education and really advance towards their professional goals. The reason that I'm really excited to be a part of today's panel is that what I found is that in working with medical students and as well as undergraduate, graduate students and other professionals, there's so much that we can learn from one another as we're doing the work to advance different causes. And so one of the things that I hope that I'll be able to share a little bit more about, along with some of the students who are joining me today, is just some of the advantages that you as medical students can take advantage of as you volunteer and work with groups in your communities. So the work that I currently do is with our Health Careers Opportunity Program, which is funded by the U.S. Department of Health and Human Services. It is a grant-funded program that is designed to help students at all levels of education, from high school through medical students, to access careers in the medical field. But in the work that I've done, what I found is that there's so much challenge with just all of the statistics and all of the disparities that give students who don't come, or even people in the general community who don't come from backgrounds where they easily do access careers in healthcare, that their health outcomes are greatly impacted by that. And so one of the things I found is that so many of the students who have volunteered with our programs, working with high school students, undergraduate students, and even graduate students, have found that they've benefited from the opportunity to go beyond structural diversity, right? Where they're just in an environment where they have people from diverse backgrounds around them, but they get those opportunities through volunteering and working with programs like like ours to have those informal interactions around diversity so that they get the opportunity to interact with people and get comfortable with people from different backgrounds, which is so important when you don't come from one of those underrepresented backgrounds, right? And you have the opportunity to really become more comfortable. And the research shows and statistics show that you are able to provide better care through those informal interactions because you learn and grow through them. So I'm excited about today's discussion, and I hope that you all have lots of questions that you'd like to ask. Thank you for having me.
Thank you. We'll follow up with Melvin.
Hi, everybody. My name's student Dr. Melvin Ways. I'm from Camden, New Jersey, born and raised in South Jersey. Went to Rutgers, New Brunswick for undergraduate in public health. Took some time in between, about 7 gap years, where I worked as a medical scribe and earned my graduate degree in biomedical science from Rowan. During that time, I collected an abundance of clinical experience as well as tutoring experience, sharpened my academics, and made Dean's List, but also took a really sharp turn on professionalism, namely increasing diversity and professionalism. I'm currently an HCOP researcher as well as an AHEC scholar. AHEC is Area Health Education Centers, and we really focus on bringing all of those knowledge and support systems to underrepresented communities like Camden and Lindenwold and Vineland, and really emphasizing how we can educate doctors to better serve those communities. And being from those communities, I'm very passionate about that mission. And diversity ties right into that because one of the HCOP's mission is taking people from those communities, helping them to become doctors, and then sending them back to those communities to make an impactful change, which I truly believe is a rightful solution. Thank you.
Thank you, Melvin. Next, we'll have an intro from Myra Kawar.
Hi, my name is Myra. I'm a third-year medical student. I grew up in Somerville, New Jersey, so Central Jersey is real. I went to Rutgers for my undergrad and my master's, and currently I'm on rotations. In the past, I've done some research in affirmation of transgender treatments for Somerset, Robert Wood Johnson Somerset, and then I did some research on South Asian health and how they view contraceptives. I've done some work with sexual assault survivors through the Zufall Clinic, and I've also participated in the HCOP Academy. So one of my dreams is to always support others in their dreams of going to medical school or whatever health profession that is. And I believe that when we support others, that can create opportunities for the future, and that will pay it forward for generations and generations to come. So thank you for having me on the panel.
Beautiful, thank you so much. Next, we'll have Ms. Arlene Muno.
Morning, everyone, and thank you, Rachel, and everyone for inviting me to be part of such a valuable conversation. I am the director of Shore Area Health Education Center, which is hosted and part of Spanish Community Center, which is a regional community-based organization in South Jersey being below Trenton. Which is always one of the jokes because people don't realize how deep rooted South Jersey is, and that although it is not rural by the definition at the national level, it is very rural in nature and very difficult when we're looking at care and quality of care for those that are underserved and minority underserved. Social work is my discipline. I have been in the field for over 30 years, and I have been with the AHEC program for 20. So I'm really excited because when I started with this program, we weren't having engaging conversations like this. And the fact of the matter is that no matter in interdisciplinary care, you can have the best of intentions in wanting to make someone better. But if you're not listening to your partners in health, whoever it is diagnosing, a physician, I tell everyone if they can't get the information and they don't comprehend the information, then the quality of their care is already compromised. It's not only language, it's cultural awareness. But I'll leave that into conversations. Thank you so much and so excited to be here.
Thank you so much. And we'll end our introductions with Ms. Martha Chavis.
You're muted, Ms. Chavis.
I'm a good friend of and colleague of Arlene Muno's and Melvin had spent time with me at our site. And I've been in Camden, New Jersey for 36 years, starting with the Area Health Education Center. I have my degree is in psychology. I've been an adjunct professor at Community College in Philadelphia for 46 years. And at Temple University, I was there for 12 years. Basically, my agency as a standalone community-based organization that provides prevention services, we have witnessed firsthand, and we're considered to be boots on the ground, first community responders to those individuals that are in need of service but are very underserved. So we work with a variety of minority populations, mainly throughout Camden City, but we also cover Southern New Jersey. And Arlene is right. We do exist here south of Trenton. Most people don't know that, but we are here. And we have a mix here in Camden City being in a dual role, because we are considered to be an urban area, but not compared to our sister city across the river, Philadelphia, which has many times more the population than we do, although we reflect their many urban issues, concern, and problems. And Camden City also is somewhat provincial in their thinking and in their ways and in their culture in terms of interacting with others. If they don't know you, they don't know you. Very simple. And therefore that may have an influence and or impact on the services that they seek and or the services that they receive. We do know, based on work done by the Camden Coalition of Healthcare Providers, which I am a board member, and our agency helped find that organization, we do know that 11% of Camden's population are responsible for 77% of the major healthcare costs in the city. So you have to ask the question, why? And being on this panel today, not only do I consider it to be a privilege to be invited, but it gives us another opportunity to openly talk about racism, especially within our healthcare system. And it's an interesting perspective you have on it. I will say that I'm probably the oldest member on this panel, so I've lived and seen things up front and personal, and as part of the profession that gives pause as to why you may find African Americans in particular being the silent minority when it comes to healthcare services, and advocating on behalf of themselves. It'd be interesting in terms of seeing what the questions are coming in and how I can respond to some of that as well. Thank you.
Wonderful. Thank you so much. So we're going to get started with our first question submitted by our attendees. So what are the most common examples of racism in medicine that you face in your profession, and how do you address them? What are some ways that you can empower others to speak up, particularly when it is a patient, student, or client? And I'm going to direct that one to Ms. Chavis.
Great, thank you very much. What I find to be the issue, and most people don't understand this perspective, that among African American, Latino Americans in particular, when you have been so long outside of the healthcare system, and not only not receiving services, you weren't allowed to receive services, nor could you engage or get your education in healthcare, let alone just general education across the board. So when it comes to actual interaction, you don't know what you don't know. You sometimes hear, well, you can advocate on your behalf. Advocate how and why and what. The assumption generally is held that the person that I've come to get my healthcare services from know what they're doing. And I have nothing as far as my heritage, culture, experience in my community, especially until recently, those themselves that are in the health profession to rely on as to what I should expect, demand, have the right to, and or the privilege of receiving. So therefore, I am stuck in what I call another land. And that's basically what you have seen over the many, many generations. I can tell you right now, it wasn't until about 1965, 70 that you even got a welcome tone going into hospitals, clinics. And I grew up in Philadelphia, which is pretty progressive. And you were not given a sense of being welcome. Now you can work there and you know what your jobs were, mainly ancillary, okay, in terms of being part of food services and or housekeeping and or security and or at the front desk or in the parking lot. But by no means were you in a had somebody that you could rely on, nor were those individuals in your families. That was just beginning to come about, especially if you live in large urban areas in the city, in cities like Philadelphia. So those are the issues. So when you say what ways can you empower others to speak up, you first have to make sure that they know what they can speak up about, where they know the baseline of what their healthcare services should be and what rights they have in terms of those services. And we're already working under the gun, which, by the way, you will never, ever get out of the mindset of most African Americans, the Tuskegee experience. Forget it. It's done. Okay. If we know nothing else, we know that we have been used and abused and treated like guinea pigs under those circumstances. So when you're walking in with that mindset, the minute you hit the door, that's the assumption that you have. And unless somebody else is showing you differently, maybe with somebody that looks like me, and or in this information technology, it matches on what I may have read and or seen on the internet. My assumption is I will not ever receive the services that are either afforded to me and or I deserve and or I have a right to, mainly because I am who I am. Thank you.
I'd also like to direct this question to Ms. Arlene Munoz.
So looking at the most common examples, and this is a very sad realization, but racism, or I like the word that has become a little less trigger, biases, the term, which individuals may use because it's a little, I guess maybe friendlier, the term, if you would. And it's, unfortunately, I see it every day. Every single day. And how I see it is within the Latino community, everything from having a limited English proficient individual, client, patient, that is not offered an interpreter in care, or they will grab just anyone to come in and interpret for them. Those are some ones that I see. And unfortunately, that is not something that I only see in medical care, something that unfortunately we see rampant in mental health as well, which is one of the ways that I overcome some of the challenges is through meditation, but personal meditation. But I think that everyone has to understand that regardless of what color you are, blue, black, brown, orange, whatever it is, you are responsible for your own actions. So for those going to be physicians, and you sit there and you're learning right now about skill set, the important thing is that And what we've seen even with student physicians is that when you're taught one thing and then you go to do a rotation and they're practicing something completely different than what it is that you've learned. And how do you address that, even with someone that's a preceptor? Well, with us, we try to provide some of the services with the individuals, but from our aspect, it's really about education of the client and the patient. We all want the person to be, the individual to receive the care so that they can get better. So what often happens is the social workers are working with community health workers, or sometimes in community-based organizations, there are community health workers that are that pivotal partner in providing care. But I think that the biggest thing with medical racism or whatever it is, it's really checking in on yourself. And as a provider of service, are you doing everything that it is that you need to ensure that that patient client understands what's going on?
I'd like to just add and feed right off of this this conversation here that Ms. Chavis brought up, which is it's the only note that I really wrote, which is we don't know what we don't know, because I think that that's the and I wrote that before Ms. Chavis said it, because I think that's the goal of interprofessional understanding on the one side, which is we don't know what we don't know, but someone else does on the interprofessional aspect, and then it's also from the patient perspective, which is how are you supposed to advocate for yourself if you don't know what you don't know, which is what Ms. Chavis brought up. And I think that that's really the crux of, empathy and understanding and meeting people where they're at. And to sort of segue into more responding directly to the question, which is, I think I bring sort of two experiences. One in particular is, I was a Commissioned Corps officer in the Public Health Service with this horrible history of the Tuskegee experiments, among many others. And particularly, I'd like to sort of share an experience that I had that's both interprofessional and with this history, which is, working with the Native American population, and in a uniform of a public health service officer. And the Native American population is also aware of the what's called when you Native American women sterilization. There was forced sterilization in the Native American population as well. So when you walk into a patient setting and you're wearing the uniform of a service in which people don't trust not only the system in general, but particularly the militarized branch of the public health service, and you're their source of care, that presents a very unique challenge for both the provider, who's trying to, in my case, trying to do the best for the patient, and to build that trust, as well as, how do I know that what we discuss in that patient interaction is going to be followed through? Because if I were that patient, I wouldn't trust this environment. So I think the interprofessional aspect of this is from the second that the patient walks or the client walks into the building for that appointment, it's about being welcoming and asking and listening and understanding where this patient is coming from, and attending to the needs of the person, the human being, and reminding them, in my case, because of the situation that I was treating patients in, reminding them that I'm here for them and only them in that environment, and then relying on my team, physicians, other pharmacists, social workers, the check-in staff at the front desk, to really create that environment of welcoming and inclusion throughout the entire visit. And that doesn't happen in silos. It happens through a concerted team effort. And I think that that's one thing to be aware of, but understanding this history and understanding this lived experience, even if I haven't personally lived that experience, is uniquely important to so many people in this country and in the world. So that's one thing. And then I'll sort of transition into another example, which is my time at the FDA. I worked with tobacco regulation and particularly sales to minors. And the focus here was to prevent retailers from selling to underage purchasers of tobacco. And our focuses were in urban areas, and because there's a culture of sales to minors through the research there. But it sort of shows, and it's illustrative of the systemic racism in our regulatory system, in which the responsibility is not on the manufacturers and the producers of these harmful and addictive products. In the law and the regulation, they've done a good job of lobbying that it's the responsibility of the mom and pop corner store owner to enforce the laws and the regulations at that level, and they're making just enough money to survive and keep their store open and support their family. And they're the ones that are being put in the situation having to say, no, I'm not going to make this sale, when it's really their livelihoods versus public health that becomes a big thing. And that tilts the scale towards the enforcement of these public health measures to the little guy that's just trying to make it by, instead of the larger, corporations that are majority, not minority communities, not just trying to make it by. And it's just interesting that even in the regulatory public health structure, it is tilted towards, ultimately it's systemic racism trickling through, because there's an uneven balance and effect on minority communities throughout this country. Then that's specific to tobacco use and underage tobacco entry into that market. So just two little areas where I think that, and particularly to the interprofessional aspect, I think, and making a change is, I was the healthcare representative on a team of attorneys that worked in this sense to do it. And it takes working with attorneys and doing research into the socioeconomic factors of these and public health research to really understand these problems and understand where the most effective place is to make a change in that. So just to sort of bring that together with what Ms. Chavis said and Ms. Munoz as well, and sort of add my little perspective on that and my experiences.
Thank you, Brian. We're going to go ahead and have Melvin jump in on this next question for us that says, how do you combat feeling like it's not your place to say something?
So for me, that's a really, I have a story about that. So when I was a medical scribe, I walked in the room and a patient was a 90-year-old Italian guy, said, "Oh, shaking the hand of a white man." And my Jewish doctor, who's the attending, almost fell out of his chair and immediately stopped the visit. And we went back to his office. He said, "Why didn't you say anything to that guy?" And in my mind, I let it go over my head. But in reality, and this is how I answer this question, is no matter what professional level you are, whether you're the doctor, whether you're the janitor, or even the patient, you inherently have respect as a human being, no matter what. Strip away the professionalism. Whether you're talking to someone straight up in whatever setting, that's a human. And so I completely lost that in the setting of the professional power struggle, where I think of myself as the scribe. I can't say anything to the patient. The patient is here for the doctor, and I'm below both of them because this is their interaction. I'm just here to do my job. And in that instance, I should have said something. I should have realized that it is my human right to stand up for myself and to be and to acknowledge that that man should not have said that to me in that context, or he could have, should not have said that. So to answer that question, it empowers you to remember that no matter what professional interaction you're having, we're people first. And that everyone has to realize that empathetic part, and that experience in and of itself builds resiliency. When a doctor comes to you as a human, he doesn't come to you as someone who's your superior, but he comes to you as your equal, or even your boss, or whoever it is. When they bring out that, they strip away that aura of professional mystique, you really connect with people and work with people in a much more effective way. And so that in and of itself is how you not only stand up for yourself, but you build resiliency and better professional working relationships.
I'd just like to make a comment to what you said, Melvin. Not only are you correct, but I always teach and reach out to everyone I interact with, no matter what you absolutely said, no matter what your job is, you have to understand that professionalism has nothing to do with your job position. It's your attitude. Name of the game. Absolutely. So that's what you work from, and I don't care what you do. And it also goes both ways. It doesn't matter what station or position that person has coming into room to get services from you. They deserve the attitude of being a professional as well. So it helps when you can share that both ways. And boy, I'm glad I wasn't you in that room, because you would have heard from me in 2 seconds flat. Okay, you're laughing because you know how I am. Thank you.
Thank you both for those wonderful contributions. I'd just also like to extend that question to Myra as well.
All right, so I think something that we can all work on are microaggressions within medicine. You need to check yourself before you walk into the room with every patient. The other day, I made a mistake. I am currently working in an all uninsured clinic with Hispanic individuals, and I had read the patient chart and it said preferred Spanish on top. First thing I did when I walked into the room, I asked, "Do you need an interpreter?" That was inappropriate of me, because what I should have asked was introduce myself in English and then ask, "Would you like an interpreter?" And if they responded with yes, then I should have called an interpreter. That was extremely rude of me, because that sets a really inappropriate tone for the whole visit, because even though you're trying to be responsible and look at the patient's chart ahead of time, you really need to walk in without that bias in your head. So this is a piece of advice I have for all of you guys. Other microaggressions I've experienced while I've been working in the healthcare field is towards Muslim individuals. I myself am Muslim, but I don't wear hijab, so therefore people can't readily identify myself as Muslim. So I have had patients where they come in dressed up hijab or very modestly with lots of layers, and I've had attendings after I've left the room tell me, "Oh my God, aren't they hot in all those robes?" So these are things that you need to consider yourself. You know what, like maybe they're wearing those clothes because of culture, but like it's not appropriate to comment on how people are wearing. Another piece of advice I have for medical students is that when you ask people their sexual history, do not ask them identify heteronormative ideals where, "Oh, tell me, do you have any male partners?" No, what you should say is, what kind of partners do you have? Leave things to an open-ended question. Then you can ask, are they male? Are they female? Both? Are you not sexually active? You need to understand that there's a spectrum to everything that you do. Some people may be pansexual, they might not be asexual, they might be asexual. These are things that you need to identify in the room. But the thing is, we are so trained as medical students and we have so little time. We have 15 minutes to get all the information that we need. Try to give yourself a step back and give yourself a moment to really determine what information do you need out of this patient and how to most appropriately make that patient feel comfortable in that room. And I will tell you, no one is safe here. Everyone has their own implicit biases. So unless you check yourself before you walk into the room, you will make mistakes. But don't forget the mistakes that you make. Secondly, the thing that I want to say, one of the part of the questions was like, how do you handle these biases? Especially if you're in a professional setting with your attendees. I need you guys to walk out of the room and ask them in an open-ended way. Do not be confrontational in the sense that you tell someone is wrong or right, because you don't know what those person's intentions were. And it's important to always be educating people in an environment where people can learn. So the other day, one of my attendings didn't realize that the person had a different pronoun preference. So what is important that when you go out, be like, "Hey, just I think this person prefers these pronouns." Be like, do you need any help like remembering, or is there something I can do to like help you? These are the ways that you can be most helpful in creating that environment. And then when you're referring to the patient, always refer to them to correct pronouns, even if the other person is repeating you back the incorrect pronouns, because through repetition, people will understand and learn things. And then I have one more story for you guys. It was during the summer, coronavirus, lots of Black Lives Matter movements. I had a patient come in who had some psychiatric issues, anger management issues. And he started off the visit telling me that Black Lives Matter is a hoax. It is a conspiracy theory, that it is a cult, that it is a terrorist organization, these kinds of things. And like I said, you have to be, like everyone was speaking towards professionalism, you need to redirect the conversations, because if you show them any bit of your opinion, whether you agree or disagree, people will latch onto that, and that will become the topic of the conversation. And that takes away from the person's healthcare. People are entitled to their opinions, but you are there to serve them, make sure they come in through the door, get their diagnoses checked, and leave feeling as if you have provided them the most unbiased and informed medical information that they have, so they can go home and figure out what they need to do with their health. So always, my advice, practice, figure out how to ways to redirect the conversation, address what they're saying, and just tell them, oh, well, we're here today to discuss your medical visit. So what questions do you have about medical stuff? You know what I mean? So that's all my advice for that. Okay, bye.
Thank you so much, Myra. Ms. Atkins.
May I just say something to Myra?
Oh, sure, absolutely.
Have you gone back and educated those who already have their medical degrees, especially some in my generation, about what you just say and how they should act?
Yes.
Because definitely I would put you in charge.
Yeah,
wonderful. Thank you so much.
You're welcome.
Thank
So
you.
So with
Myra,
the
you're
pronouns,
amazing.
yes, I have. It's just like really sweet. Like you need to come in with an attitude where if you were trying to explain something to your parents, you were trying to explain something to your neighbor, some person in the elevator, you need to not be on the defensive, because people get really annoyed when you're defensive because they will retaliate back to you. Just be like, hey, so what do you think about this? Ask them their opinion, figure out what they think, and then just, slowly sprinkle in little things like, hey, I think they prefer their pronouns this way. Some people like to identify this way, and just make it a conversation, not an authoritative, like you did this wrong sort of.
And I think asking open-ended questions, I think that's perfect. Asking open-ended questions with a true sense of wanting to understand why they feel the way they feel and not with an agenda is the best way. And that will open you up to be able to interrogate in a friendly, open, honest way, that when people usually see what they're accidentally getting at because of their biases, they typically stop for a second and think. And it's really incredible to see that change.
Thank you all. I just wanted to extend this opportunity to Ms. Atkins to get in on the action and add any comments if she had any.
Certainly. Thank you so much, Rachel. One of the things that, and there were two things, both when we were talking about, how do you address the issue of bias in medical settings? For me, one of the things that I am constantly challenged with is how do I motivate students who are coming from underserved backgrounds to believe that they can do this. And part of what I found to be so effective for those students is those interactions that they're able to have with current medical students. And the medical students, what I found, and you can hear it in Myra's voice, they're so informed and are very, very passionate about being agents of change as we move forward, that the doctors that our students are seeing now, who maybe they might not be inspired by, are so different than the doctors that are coming along in the pathway. And so that's one of the things that I just want to encourage every medical student to get involved in the community, to reach out to younger individuals, to be able to help those students to see themselves in you, not necessarily see them people that look like themselves, but see enlightened individuals who are self-advocates so that they learn those same strategies and are able to contribute to their communities in the same ways that you are. And that's what I've seen as an impact of the work that we're doing, is that when those students have those opportunities to interact with student doctors, they get that inspiration and they see themselves in our student doctors, and they realize that yes, they can do it, so that we can turn the tide on these low rates of underrepresented minorities entering the medical profession. So that is so key and so important that we not just focus on moving forward, but we also reach back and help those generations to come to really enter the medical field at higher rates and to believe in themselves. Thank you for the opportunity to share that.
Thank you all.
Oh, sorry.
And I know. Oh no, go ahead, Brian. Sorry.
I was just going to jump off of what Ms. Atkins said, because I often think that, especially getting into medical education and all that stuff, I'm well aware of my privilege that I carry as a Jewish white male, cisgendered, heterosexual. But I think it ties into the medical education and the pathway in, as well as patients and in any setting or clients, whatever it might be. When a common question is, what would you do? Right? To a physician, to a pharmacist, to a nurse, to a social worker, whatever. What would you do? And I think it's so important to understand they don't mean what would you do? And they definitely don't mean, if we're not from the same background, what would I do? Right? They mean, what do you think I should do with my capabilities, with my resources, and understanding that? Because I'll give you an example. When I was a student, I was out in Navajo Reservation, which is how I found out about the Public Health Service and Indian Health Services. And they, on the Navajo Reservation, do not have running water and electricity for about some percentage that's relatively high, 30% of the households there, something like that. Don't quote me on the number. But so giving a patient that needed insulin, some insulin, they asked, how should I store, how would you store this? They said. And I said, oh, well, I'd put it in the refrigerator and I would, take it out, when it's time to use it, and you can leave it out for the month. And they go, oh, well, I don't have a refrigerator. I'm like, oh, well, can you get like a little ice box that you can plug in for? And he said, well, I don't have electricity. And then we were talking about alcohol pads, right? And because they don't have the ability to wash their hands because they don't have running water all the time every single day. And it's just this understanding of, it's not, they don't want to know what white privileged, East Coast Brian is going to do. I'm going to get in my car and go, but, they want to know, that I understand where they're coming from and their needs and their capabilities, and give them a recommendation based on that. And that is across the board in every service that we come into contact with, but that's also with medical education. So I would do a Princeton review course for $1,500, and I would do XYZ to get high scores on this and this. That's not accessible to everybody. So especially for people that, whatever your privilege is in any setting, I think it's important to recognize that that's not always, what works for you is not accessible for everybody. Yeah.
Thank you so much for making that point, Brian, because that I think is one of the challenges, right, in helping individuals who come from different backgrounds to access, who haven't traditionally have access to medical education, right, and they haven't traditionally understood the pathway or had the support that they've needed to be successful. It's just really helping those people who are in the pathway and have had the privilege and have the resources to realize that they are important to that person's success, right, to being able to undergird and provide that bridge. And so, through the work that we're doing with having our student doctors constantly interfacing with our current high school and undergraduate students, it makes such a difference in their experience because they understand that there's more than one way. Just hearing your stories, you being transparent and authentic when you're talking to those generations that are to come. Dr. Hall in her talk talked about the fact that there are only 2% of physicians that are Black women. So we need other people to step up, right? We need people that come from different backgrounds to understand what this pathway looks like and work to help the students to realize that, no, your pathway is not the same as mine was, but you can still do it. And here are some resources that you may not have known about or you may not have had access to, but I can still help you. Even if I don't look like you, I can still be supportive. I can still provide wonderful care. And you can tell your parents about how you met this wonderful physician so that they have more trust in the medical care system. And we see those numbers turn around.
One thing that you pointed out, both Brian, both you and you, Vanessa, is the backdrop of that systemic racism. To get that kind of story and transparency and information from the individual, You need more than 8 minutes. Okay? We're working with a standard that, once again, as a white person coming up with this particular background, that overall 10-minute visit with the physician is enough, because they not only know what to say, how to say it, what the expectations are, and they're familiar with your background because they come from a similar background. For us to really get this kind of information out of people that we don't know means that we have to give them a little bit more time. And we don't address that. That is one of the backdrop issues of our systemic racism, that we put everybody on the same page thinking that they need the same amount of time, and that is not true, nor does it exist. And we have to learn and they'll come up with some way of tying that in. And matter of fact, if the healthcare industry would look at it as a cost saving, rather than it being not cost effective or cost efficient, you'd be surprised what you will not have further down the road, because you now understood, as Brian pointed out, which, by the way, I still don't believe you're over 16, Brian, but that's another day, another story. Got that wonderful young man's look. That he pointed out in terms of not having electricity and or water, obviously would end up affecting their health in the long term, making their care more complex, costing even more money, when you could have just taken that time up front. That is part of what is going on. I run a needle exchange program, first responder in terms of the needle exchange program. And I don't know, but based on my experience and understanding, nobody ever that I've come across so far ever woke up one morning and says that I want to be an intravenous drug user. Okay, I want to be a person who injects drugs on a daily basis. However, I have gotten in the past, not so much these days, so much backlash that I am creating that person to continue on drugs, when I know that 10-cent needle that I have in exchange of making it clean and making it safe for injector keeps that person alive one more day, to finally enable them to have make a decision about not only dealing with rehabilitation, but also handling other issues in their life, so they don't have to be on this particular road continuing this way. So it makes a difference in terms of understanding where that individual comes from. And, you know, finally the light bulb is going on in so many people's heads saying, 10 cents, wow, that is really a cost saving rate in terms of further going down the line with that individual with even more mental health and physical health issues, and potentially illnesses, and knock on wood, but sometimes even death is costing us even more in terms of lives and a hit to our services. So what you two have so very nicely pointed out not only makes good sense, but it also points to that backdrop of our systemic racism, and that we are not affording the different kinds of customized services that we need to utilize. And I'll give one more example. If we do what a jewelry store does in terms of treating that customer walking in the door, and we doggone well know, I don't care what anybody says, the jewelry does not necessarily, okay, serve as the basis of food, shelter, and clothing in our lives. But if we were to afford our customers coming in, our clients, our patients coming in through the door for health and human services, the same way you get greeted by that associate in the jewelry store for you to buy a piece of rock, okay, that we won't even talk about how it was mined, but the fact that you're paying for something so small that has absolutely no other role outside of a memory and something to shine, you'd be surprised. And I sent many of my students and staff to jewelry stores to learn how to interact and treat a customer, because you talk about non-judgmental, voila, they are among the best at being non-judgmental. But I know one thing, you're walking out the door spending more money than you even ever thought of. And in the meantime, you feel very satisfied in terms of that interaction that you had. I'm off the air now. Bye.
And just to follow up on that, I really love all those great points, and I want to touch on each and every one of those because being a Black kid from Camden, it's very much easy to have this all or nothing attitude where it's either I got to be a doctor or I'm nothing, or I got to be a ball player or I'm nothing. And what Miss Atkins really emphasizes at HCOP is that we expose them to all medical professions, not just being a doctor. If you don't want to be a doctor, you can be a nurse. If you don't want to be a nurse, we need president of hospitals. You don't want to be that, we can use somebody who starts a clinic. So like a social worker. So it's all across the board where when you change this issue of systemic racism, you need players at every level. We don't just need doctors. We need people doing politician work. We need people doing policy. We need people at the ground level doing works in the clinics and social work. So that's one thing Ms. Atkins really emphasizes at HCOP is we show these kids multiple options. And that exposure alone, and I'm telling you this anecdotally, but truthfully, when kids see that, when kids see that there's a separate way, when they don't have that all or nothing vision, when they can see like, oh yeah, I can be a nurse and still make it, or I can be it changes a whole perspective for them, even from the very beginning. And that's very important. Like that exposure early is key. And even later, like in Brian's example, like he had a life-changing experience going to this reservation as someone who was already probably cemented in a lot of his ways of thinking. Like he already knows he's this heterosexual Jewish male, but he went to this reservation and still learned something new about himself and knew about the way he wanted to live his life and treat others, which is, it goes both ways as well. Like not only do you pull people out of bad situations by exposing them to good things, you can pull people up to a higher elevation of enlightenment by exposing them to other people's lives who might not be as fortunate as those. And then, you know, to combat systemic racism, that exposure combined with showing people alternative options, you completely abolish the system, because there's no way the system can survive when people see beyond those small limitations, which are very much, you know, inherent. People hold on to those themselves thinking that I can only do it this one way. But when you take those barriers off, which is what I really try to do for the kids that I mentor, it really lets people fly. And it's something that I use personally. I don't tell people stuff that I don't use in my own life. It's something that when I, you know, so I didn't see my first Black doctor till I was 18. So up until that point, I wanted to be a football player. But once I saw my first Black doctor, who's my stepdad, I was like, damn, I could do this too. So it really does work. And that's the importance of these programs and interprofessional development, showing them that it's not just, I'm coming down to your level. I'm not just a doctor, I'm a professional. And if you can do a nursing profession, if you can do a research profession or politician profession, we're all at the same level combating this system that is holding us back.
I just wanted to add one quick comment, and Ms. Chavis brought it up, and I don't know if you all will agree with me with experience in big healthcare systems and public and private sector, but something I always keep in my back pocket, because I realize I cannot change everybody's mind, is dollars and cents. If, like with the needle exchange program, that saves hundreds of thousands of dollars, millions of dollars in treatment for HIV, hepatitis, all this other stuff, and just, it saves lives, but when you can't change their mind sometimes, as frustrating as that is, I always remember I can pull out my utilization report and how much we're spending on the treatment on the back end, and it will save the healthcare system, either private sector or the public sector, so much money, and that tends to grease the wheels. So I always just keep that in the back, in my back pocket. So if you're at a site and you want to change something, always do the cost-benefit analysis too, because that will help.
Before we depart, I do have some advice for you guys on rotations. I know you can't always show that you're an advocate for people, but you can physically wear things of affirmation. If you could wear like a pin maybe on your jacket or a talking point, you know, your pins don't have to be medically related. They could be like a piece of artwork or a piece of food or something. That's something that I would say would be really helpful. Secondly, if you don't feel like you've spent enough time with the patient and your attending leaves, you stay with the patient. You walk the patient to the front desk. You help the patient off their chair. If you're doing an OR surgery and your attending walks out and the surgery's over, you better go and run and go get blankets and wrap that person's body as if they are your own like family member. That is something that's very important. That shows that you care. Secondly, when you're on rotations, do not always spend all your time with your attending. Go to the social worker. Ask if you can spend an hour with the social worker. Go to the nurse. Go spend time with the nurse. Figure out what they're doing. Figure out what's happening with finance. Teach yourself, educate yourself on what is proper insurance. Figure out what is the federal poverty guidelines? If you don't know what people need to make in order to get your services, that's a problem. And the last piece of advice I have for all medical students is that if you're not providing continuity of care, you're messing up somewhere along the line, because the best outcomes are when you make a relationship with that patient. So I have this thing where, like, if you're going to go volunteer somewhere, make sure that you make it your mission that the moment that you leave that room, your care doesn't stop at the door, that somehow it is paying it forward. So when you go on these medical mission trips overseas, make sure you create an infrastructure that will not fall and break apart. When you talk to your patients, make sure your relationships don't disintegrate. That is something that is so important that we always forget, because we like to slap a Band-Aid on things and think that things are fixed when they're not. And if you're going to be mentoring students, you better give out your phone number, you better give out your email, and you better make time for those people. Because if you're just going to be there just for lip service and giving them advice and not following up on them, then that's a problem.
And Myra, thank you. I think that those pieces of advice that you gave are amazing. I just want to echo that and say that in terms of any service learning opportunity, that we ask that you approach that with intention, right? That you want to consider that you want to think about what you can give, but you want to make sure that what you're giving is what's actually needed, right? You don't want to be giving what people don't need. And the other thing that you want to be thinking about is being reflective as you're going into the situation and preparing yourself mentally so that you understand differences and you're seeking out a basic understanding of why those differences exist, and then what barriers could exist as a result of those differences. And then finally, to expect to learn and be open to it, right? To think about, as I'm going through this experience, not just what am I giving, but what can I take away? How can I grow in my understanding of this culture, of this grouping of people, of what their challenges and struggles are, so that I don't let my bias take over and I don't then become a part of the problem instead of a part of the solution. And you'll be a great asset if you can just keep those three things in mind and make it a point to be of service and not just to be present.
Thank you all so much for those amazing, amazing comments, words of advice. I'm truly feeling inspired. And I know we ran a little late, but I think it was super worth it. So thank you again to all of our panelists. I'd just like to offer you all 5 more minutes, just if you wanted to offer any closing statements or last minute words of advice before we bring on Adrian Williams to give our closing remarks.
Yeah, my bit of advice when I always talk to my mentees is make it personal. If it has to be intentional. It has to be something that really, really sticks to your core. So when I say I want to be an AHEC scholar and I want to get back to Camden, that's something I dreamt about before I came to med school. Like I saw that Lady of Lourdes Hospital and I said I wanted to be there. And every step of the way I made it intentional. I didn't just do volunteering in Camden because it was something people were doing. I really want those people there to get better. I look at them, like Myra said, like they're my aunts and uncles. So make it personal, make it intentional.
I think just from whatever perspective, I think it's important wherever you are, wherever you're learning, wherever you're giving back, whatever it is, listen, learn, feel. I think that we forget to feel sometimes. That comes in with the 8-minute visits, and try to emote with people, and that goes much further, I think. So that'd be my advice.
Thank you all so much. Yeah, I was just about to bring you on. My co-partner, Adrian Williams, go for it.
All right, I just want to say thank you to all of our attendees. You guys made this program great. I thank you for all the questions that were asked and posed to us. It definitely helped. We've been receiving messages from people on the side that, they've been impacted by today. I just want to give a couple quick shout outs to people that made this possible. Especially with this pandemic, it's been a little rough for this to be online and just being in communication with everyone, receiving a million emails. So first, I want to start off by thanking Rachel Fletcher-Slater. Along with myself, we were a part of the content committee, making sure that we got all of our panelists and things of that nature. Next, we have Wally Cameron, who he ran the finance. So we appreciate you. Alojai Abuzit, she was PR. Rosie Weinrich, Andrew Vu, Shreya Patel, Sahil Savarna, And then next, I just want to thank our General Planning Committee, who basically oversaw this whole thing and made this possible. That's Michelle Bahatiarian, Natalie Calderon, Elena Frugalius, Shruti Nanduri, Grace Bogle Toko Bongda, and Dylan Perez. We appreciate you guys for all the dedication. We had an exam yesterday, so I know that it's been a little stressful, but we definitely thank you. And then I want to give a thanks to all of our panelists today, Dr. Brian Thomas, student Dr. Melvin Ways, Mrs. Vanessa Atkins, Arlene Muno, Martha Chavez, Myra Cara, Dr. Paul Furtaw, Dr. Chanel for giving our keynote, Dr. Kristen Birch, Charles McDaniels, Rashida Bochi, and Chloe Samarikun, who were all on our panel today. We appreciate you all for your time. And finally, I just want to give a thanks to the financial part of those who made this possible. So special shout out goes to Geisinger Commonwealth School of Medicine and Perelman School of Medicine of the University of Pennsylvania. We appreciate your contributions. And our gold tier donors for Temple School of Medicine. And then our silver tier donors were Philadelphia College of Osteopathic Medicine, Drexel University College of Medicine. I definitely just want to run off all of those names and those, and also I'm sorry, Dr. Dean Machichi for all your contributions and making sure everything went smoothly with us today. And Dean Cavalieri also gave a small presentation earlier. We appreciate everything. This meant a lot to everyone on this committee. That's why I think we worked so hard. Our voices were heard, we feel like, and we hope that this continues even without this conference. You know, as we go on our daily lives, I hope that the attendees grasp something from this and they're able to take that to the next venture. As well as our panelists and our participants, I just hope you had a great experience. And please, any feedback that you may have, let us know. Any questions that you may have, let us know. And these sessions were recorded for anyone who may want to hear them in the future. So again, thank you all, and I hope you have a great and beautiful Saturday. Thank you again.